I have to say something. So I'm a glaucoma specialist. I have to talk about vitrectomy. I guess there will be a funny talk. So no, but yes, Thomas mentioned it. We're working together with Oertli, and I love this collaboration with the company because Oertli is one of the only companies who listens. They listen to the surgeon. So, and they invites me once a year, twice a year to show the new products, to develop new products. And that is so unique. And that makes a difference in this. No, it's not anymore a tiny little Swiss company. It is a huge company in a lovely countryside in Bernach, Switzerland. And please ask the members from Oertli to be able to join them because it is a unique experience to be there. So, but now into topic. I was asked to talk about vitrectomy. And first of all, then you have to look since when we are doing vitrectomy, and all of them starts. And now I'm realizing I'm really old. It starts in 1969 with Machemer, with the first postplanar vitrectomy. And one of his colleagues developed, and I love this, the vitreous nibbler. Okay, whatever this means. So, but a couple of years later, and then 1971, and now you see the long connection between Oertli and vitrectomy. Cloete developed with the Oertli company these famous Cloete stripper. And I started my career in vitrectomy, which my first surgical platform was the Orbit, and the second one was the EOS platform. And then we started with these Cloete stripper at the beginning. So you see, I'm really old. So, and over the time, there was a huge development now from in the early century with the 25 trocar vitrectomy, which I love, which becomes standard. And then after 2005, Eckert 23, 2014, Ozawa with the 27 gauge vitrectomy. We have now, and it's not yet functioning. So the hypersonic vitrectomy 2019. But a lot of these new inventions were adapted or invented by Oertli and adapted by Oertli and developed to a better standard. And you see here one of the earliest vitrectomy cutters. And if you compare it now to that what we have here, it is a complete difference. So here you see 1971, and that, to be true, it looks quite modern. It works different. So that was these you couldn't work close to the retina because there was a push out in the vitrector. So, but now we have these, all of them are driven by a pneumatic pump. And the unique thing is, so we have a couple of inventions, a lot of inventions done by the company, which forwarded a standardized vitrectomy so fast. And I love to have all these features in the platform, in the OS4 app or in the previous OS4. So we have these dual linear foot pedal, which was invented by Oertli, no other company. So, and if you try to do a controlled vitrectomy with less suction and you are able to adapt the cutting rate in dual ways, which that gives you much more control. I'm doing a lot of floater vitrectomies, and patients only have some vitreous floaters. And in this, you're dealing with an eye, usually with a 20/20 vision or 25/20 vision. So, and then you have to be absolutely sure that there will be no additional traction on the vitreous. And with a dual linear vitrectomy cutting system, I'm able to manage this easily. So then, of course, we have these combined Venturi Peristaltic dual pump system. We have the pneumatic vitrectomy cutter from 23 down to 27. And then in 2008, Oertli announces the first auto-seal trocar system. So since then, we are able to do a really stable vitrectomy, a trocar-driven vitrectomy under standardized conditions. So, and then the next step were 2011, one-step system, 2014, the caliber trocar system, and in 2015, the continuous flow cutters. All of these inventions which made vitrectomy more predictable, safer, and easier to use. And today we always ask ChatGPT first. So what shall I do? So if I remember, I give my son a suggestion and he will take his iPhone and ask my question into ChatGPT. And I said, no, Dad, it's a wrong answer. ChatGPT told me this. So and what I'm doing is I'm asking ChatGPT, what are the needs and requirements of a trocar system on cutters and vitrectomy? And with the ease of use, safety, predictability, high efficiency, and fast recovery. Yes, quite easy. But how to deliver? So what are the surgeons need on the trocar systems? I don't want to have any surprises. It should be easy, like cutting butter into the eye. So it should stay rock steady there without any movement during my vitrectomy. And stable means, on the other one, watertight. So no lose of control, no lose of pressure, no hypotony during my vitrectomy to prevent any accidental contact to the retina or to tissue I want to cut, don't want to cut. So minimal stretching of the wound, that is closing immediately after the surgery. Most of my cases are now without any suture, also in eyes where I had to add some oil at the end of the surgery. So how about the cutter? It should be high efficient in all sizes. And we are going down now. My standard is 27 gauge for nearly 80% of my vitrectomy cases. The next step is 27. I haven't used 23 since 2 years anymore. So, and that needs really a precise instrument and an instrument which is effective and works in every situation. High speed, continuous flow, all these are features offered by the new Oertli system. So how about the trocar system? So, and we see here the trocar, and a unique feature of this new one is that we have a releasable and readaptable, but that seems to be a prototype. Now, so it works this way. So you can remove it. So to be true, in my hands, there is often no need for, but if you need to remove it, especially in fluid oil exchange or injecting of fluids of high viscosity, it is very helpful. And then you can close the valve again and the eye is rock stable as well. So the new trocars come as a single-step trocar system with a marker at the back, so 3 and 3.5 millimeter. We have a beveled cannula, and if you compare this to the force you needed in the previous system, it is now it glides in with any resistance. And to be true, I was talking about the Caliburn system from 2014. And one of my colleagues, Hakan Kaimak, published this paper together with Karsten Meyer. And that was a previous version. The previous version, and that was cutting the design and the cutting power needed to pass through an artificial sclera compared to others. And still on this, and that is 10 years ago, Oertli was the company which offers the sharpest knife with the lowest power needed to introduce into the sclera. But there was one backdraw. There was an interdigit zone between the knife and the trocar. And there's often added an additional resistance as shown here. So knife only, now you insert the cannula and there is an additional resistance. But with a special design of the beveled cannula of the trocar system, which is shown here, it's becoming smaller and then slightly beveled. These resistance was significantly reduced, and usually you don't feel these slight stepping. Usually it goes in without any additional resistance, without any stepping. And the other thing, it stays on place during the vitrectomy. Nevertheless, how often you change the instruments or the trocar. So the trocar itself, as mentioned, so comes with these removable valve. So, and it is yellow and that happens. So the company was so kind to offer me a prototype in front of the ESCRS to test. And yes, of course, I removed it and I left it. So, but it is yellow, you will find it, to be sure. So easy to remove and easy to readapt, to have always stable conditions with vitrectomy, because that is the goal of a 3-port vitrectomy, a stable eye in all phases of the procedure. The next thing is, how about the infusion? So we have now a higher outflow, we have highly effective cutter systems, and we're working usually with really high vacuum. So what means it should be an inflow which is effective enough to hold the pressure in the eye to have a stable eye. So and the new inflow system was adapted once to the new trocar system, and the diameter allows a higher inflow as shown here. The darker greens are the new systems which allows a higher inflow, which means a higher stability during the vitrectomy. So here we see the color-coded new vitrectomy trocar, one-step trocar system as 23, 25 and 27 gauge, which are now coming with the OS4 up in the next year is the market launch. So and that was the first surgery with the new trocar system. So you see, we have the marker and then slight dislocation. I hate to touch the conjunctiva with the forceps. It causes bleeding. And then you go in after marking, one step, knife out, position, done, very, very stable. The connection to the infusion line, the valve will stay in place with a slight rotational move. It is fixed and it stays stable as well, which is important. You don't want to lose the infusion line during the surgery at all. So removal, disconnecting, easy. You see this really high flow, and that is 25 gauge to be true. That is a huge amount of fluid which is able to enter the eye. So there is no risk of, and here we see, okay, I cutted the situation out where I lost this. So easy. I would suggest to do this while stopping the infusion for a second, but you can do it under irrigation as well. So, and now it's tight, it's watertight. And here, now removal, and that is important. So we were talking about patient's expectation, or we are oftenly talking about patient's expectation in cataract surgery. So for my perspective, vitrectomy patients now have the same expectation. There should be a calm eye. It should be stable. In cases of routinous vitrectomy, floater vitrectomy, epiretinal membranes, we don't do any air tamponade anymore. So the eye is quite stable, and that is 25 gauge. So it is much tighter, much watertighter with 27 gauge. And it's not uncommon that the patient has a vision of 20/25 day one without any bleeding, a calm eye. And that is the patient for asking for. They are feared about, I see a bleeding, doctor. There is a conjunctival bleeding. Was there something wrong during surgery? So these are patients' expectations growing up over time because we have so safe and smooth vitrectomy systems now on the market that we can deliver. So how about the cutter? So vitrectomy, the trocar system is done. Ease of use, good and adaptable ergonomics. So, and that is not a mistake. You can adapt it. Some of you love it to have a huge or larger, I call it the Meisterstück pencil. But you can, some surgeons love to have a smaller handpiece. You can remove these plastic sheet. Highly ergonomic, stays in place, and as long as your nurse connected it right, it is easy to readapt. So next step It should be stiff enough. So the OS4, we have how many? 2 at the moment. Platforms here, 4. So just ask the Oertli dealer. I show you one, and that is especially if you're dealing with smaller diameters, is you hear the cutting. And it's a unique feature because we have a double valve active push-pull system. So there is no company which offers you a cutter working in this condition. It snaps back. So, and that is about an angulation of about the company would not recommend this. So I see Thomas, okay, what he's doing. But it is still cutting. It is still cutting because there is no spring inside for a passive retraction. It's an active system and it's a very powerful system. In 23 gauge, it doesn't matter. But if you walk with 27 gauge, which is much softer, it becomes stiffer over time and there is a modification now. But of course, for obvious reason, there is a softer system in 27 gauge, but it works absolutely stable. And that is what I'm loving. And they were able to increase the stiffness on all of these 3 different sizes of cutters, and especially in the 27 gauge cutter system up to 81%, which is huge. So then they've modified the lengths. And you will tell me, okay, we can't do any high myopic eye with a 27 gauge vitrectomy. You can. And most it will fit, but reducing the lengths increases the stiffness additionally, beside choosing another material. And you see, comparison of the stiffness to the previous system, especially in 25 and 27 gauge, improves significantly. So we have seen that the inflow is much higher with the new infusion line. So that allows a higher aspiration as well. And 27, you will tell me, okay, it improves only for 5%. Yeah, but we all know. And I remember I was asked to do the vitrectomy course over years with Professor Norbert Bornfeld from the Essen University Hospital. And he was always complaining about 27 gauge vitrectomy couldn't work forever. I'm slightly disagree. It works perfectly. We know there are limitations due to the smaller size, but it's with a new platform, with new aspiration modes, with higher efficient pumping systems, with adapted infusion systems. It is doable and it is effective, as to be seen here. Nope. That's the video is. Oh, yeah. No, there was a video, but it's not anymore there. So once again, I mentioned it before. Most of the cutters on the market, there's one exception, but that is Alcon. But Alcon adapted this here from Oertli. Is these active push-pull. You have 2. That's why there are 3 lines on the vitrectomy. We have the aspiration line, and we have 2 lines which offer pressurized air and a high-speed valve system. And you have an active opening and an active closing. And that's why it works in such conditions. It's very stable, very predictable, and it is very fast. 15,000 cuts, true 50,000 cuts doable. We tested a higher frequency up to 20, but you can't hold, then you have a frequency which causes a really uncomfortable, some like a noise. It's first of all, it's very loud, and otherwise we have vibrations. You can't hold the instrument securely, but true 15,000 cuts are doable. And we see here then the continuous flow cutter. Once again, an invention by Oertli. So we have the cutting edge is very, very small, and it will never occlude the opening completely. So there is a continuous flow, and you see it here in a high-speed camera view. This is these stop, flow, stop, flow, stop, flow with a normal cutter system which closes completely. Here we see a continuous flow cutter, and you see it never closes, and then there is a continuous flow, and that prevents pulling, and that prevents a movement of the, and we see here a triamcinolone vitreous, and there is less movement while an effective vitrectomy is done. So less traction to the retina, more control, easier to use, and very efficient. So, and I've mentioned patients' expectations, fast and painless surgery they expect to have. There should be a minimal surgical trauma. The recovery should be fast. A lot of patients ask me, may I can drive my car next day? Okay, I will ask, please stay for 1 week. But most of the patients have a good vision if there is no other condition. But after vitrectomy, they are achieving a visual acuity of 20, 25, day 1, day 2, and they're able to drive a car within 2 to 3 days. Less pain, of course, for obvious reasons, less bleedings for cosmetic reasons. And that is, by the way, if you have a look on Instagram and looking for a vitrectomy, then you got this picture. A beetroot eye. So I wouldn't like to see this, to be true. So patients expect not only in refractive surgery and cataract surgery, a really calm, a wide eye with a good vision day 1. So, and we can fulfill patients' expectation. Fast and painless surgery due to the high-speed cutter to a stable trocar system, which doesn't stretch the wounds additionally. The reduced surgical trauma with an immediate closure of the wound. And so quick recovery. We don't need any sutures in the very, very vast majority of the cases. Means 27, 25 vitrectomy. I usually don't do any suturing. 23, if there is a thin sclera, sometimes it's needed, especially if you use silicone oil, but 50% are need sutures in 23. But as I mentioned before, I have done my last 23 gauge vitrectomy about a year ago. So, and due to the minimal conjunctival laceration, less inflammation, no suture, there is less post-operative pain. So we have now the one fits all. We never will have, but we have a nearly perfect system with a new trocar and a new cutting system for vitrectomy, which fulfills patient expectation, but at first, surgeons' expectation, surgeons need on a controlled, highly efficient, safe, predictable surgery. Thank you.